We talked about AFib burden and how I kind of break that into three buckets: the very small amount, the moderate amount, and the high, almost continuous burden of atrial fibrillation. There's a few other things I go through. One is kidney disease, because it's very controversial in patients with stage 5 chronic kidney disease and end stage renal disease. These patients were excluded from most of the trials that we like to cite and lean on in terms of stroke reduction. Though these patients have increased risk of thromboses, they also have uremic platelets or an increased risk for bleeding. So I pump the brakes sometimes when we see higher CHA2DS2-VASc scores in these patients and we're trying to rush to anticoagulate them. I think that more shared decision making should be involved with the patient, that we don't really have a clear risk benefit profile. And if that patient is bleeding, I certainly I err toward holding off anticoagulation. So there's kidney disease, and then gets into some things with an echocardiogram, which ultimately is inevitably ordered with most of these patients if one hasn't been ordered before. I think left atrial size is important because that often can be a marker of how atrial fibrillation has been there before. And not that just because someone has a big left atrium, we would anticoagulate them, but it helps kind of put the story together. There's two medical conditions that are known to have higher stroke risks and kind of fall outside the realm of the CHA2DS2-VASc score, and that's hyperthyroidism and hypertrophic cardiomyopathy. So those patients usually would err toward anticoagulation regardless. Very controversial thing that we see, it's been published on a little bit, is actually the presence of severe mitral regurgitation. In some ways, you can actually almost think about this mechanically, can be protective for thromboembolism. We actually see this on TE, such vigorous mitral regurgitation that it almost looks like it's washing out the left atrial appendage, in fact. And you can see the flow going back into the left atrial appendage, going back into the pulmonary vein. And these patients with wide open mitral regurgitation, we very rarely see left atrial appendage thrombi in these patients. Not that I would take caution to the wind with those patients, but they are at somewhat lower stroke risk or lower left atrial appendage thrombus risk.
We may see people who are chronically paced for another condition. You're wondering if that provides the lead protection, given that you're having more induced atrial systole against left atrial appendage, thrombus formation, or just stroke risk in people who had AFib previously.
The patient is in atrial fibrillation. The atrial lead is suppressed. So when a patient is in AF, the A lead is not pacing, it's just sensing. And so you're essentially turned off the atrial lead. The atrial lead is suppressed so that there is no protection of having an atrial lead there. It won't be pacing at all, because what the atrial lead is sensing, if you actually go to interrogate the device, is atrial systole 400 to 600 times a minute, which will suppress any pacemaker activity.